Hey guys, here's your How to Survive for Camera Thompson Part 2. That's right, she's back. So we already know that Camera Thompson has the flu. We learned that in Foundations of Medicine, and that's not going to change here. But flu is a big deal. It's killed millions of people. It's the most deadly virus, if you ask me. Not necessarily because how it affects your average person, but because it's what it leaves them susceptible to. So we're using this case a couple of times. One, to drive home the importance of flu. Two, we used it in the beginning because it's something that you're familiar with. Everybody's had the flu at some point or another. We all get vaccinated for the flu every year. And those of us who can't, it represents a significant public health concern. So that's one reason. The other thing is, when I taught it to you in Foundations of Medicine, I didn't actually teach you the flu. If you go back, I taught you about viruses and I taught you about like generalized replication of virus, but it was all very soft. We weren't really talking about the flu per se. So now we're going to actually talk about the flu, and we're going to talk about other viruses that go with it. As you know, your clinical skills session on Friday has been canceled. But that leaves you a little extra time. We're not going to jam pack it with a whole bunch more to do, but this one is a little bit longer than Katie Diaz and Leah Smith was, but it's still shorter than things like Jamie Lopez or Miriam Khan, okay? So let's go through it. So you have your case presentation. It's the same as the one that you got in flu. We didn't add anything to it. So if you've already watched it, you don't need to necessarily watch it again. Physiology. So physiology is taught to you by Dr. Shannon, who is your next course director for vital fluids and gases. He is amazing. You guys are in very good hands with him. He's a phenomenal course director. Most of his materials are in EPUB files, and I'll go through a little bit about that. Here's my content. Immunology, you've got your hyperlinks, you've got your times, and microbiology. I still have to record your influenza video. I'm going to do that right after I record this one. We're going to go through a couple different viruses: flu, measles, RSV, parainfluenza. There's not going to be a video for parainfluenza. It's a pretty simple virus. Mumps, adeno, and rhino. Again, no video for that one. Okay, here's your video. And then physiology. Okay, so what do we do about physiology? Dr. Shannon likes his EPUB files. The format allows him to put his videos in there, his images, lets him write on them. He just finds it a better method. If you have an iPad or a Mac, not a problem. You can open these EPUBs without issue. He did check with OMSP and found out that you guys were still all being issued iPads, so you all have the ability to use that. There are some other methods for doing it on Android or PC devices. You can find that here using Firefox. Here's how to install it. There is also other readers for Windows that they've tried, and if you find a better solution to this problem, let Dr. Shannon know. And if you're having trouble with it, you can also just contact Dr. Shannon. There are a couple instruction files that I will hyperlink here after loading them on Entrada. Internet was down this morning, as many of you noticed in your CBCL session. So as soon as the internet gets fixed, I will upload these EPUB files that you'll need to go through. But these are the main ones. This one is about, I think, 25 pages long, but it's 25 EPUB pages, which I guess is about the equivalent of about 15 standard pages, 12 to 15. Same with this one. So you're looking at about another 25 or so pages, but he tells me that there's a lot of calculations in there, and that basically one should only take you about half an hour to go through, the other one about another 20 minutes to go through, and that the calculations altogether should be about an hour. So according to Dr. Shannon, his session should take you about 2 hours to go through, just to kind of orient yourself. He also provided some calculations here that you can use to practice. You aren't required to, but you can utilize them to kind of go through. And he shows you how you could fill this out, answer by answer, so you can kind of play along as you go. Okay, then we get down to immunology. You guys should be pretty familiar with how my stuff works by now. Right now, we're going to work on completing the immune response, because presumably Camera is going to get over the flu, and she will. But how are we going to stop the immune response once she does? So we've been amplifying the immune response all the time. Now we're going to start shutting it down, okay? So basically, we use what's called peripheral tolerance. These are mechanisms kind of like central tolerance in your primary lymphoid organs that we use to stop the immune response. So here's the video hyperlink for this, stopping the immune response. And it goes into kind of the two ways we do this. Now, the important thing with peripheral tolerance is that we don't just use it to stop the immune response once the pathogen is gone. We also use it to keep ourselves safe from self-antigens. Self-antigens are expressed at all times, and occasionally you're going to have a T cell or a B cell come along that's specific for that self-antigen. And we need to find a way to stop that response before it gets any momentum behind it so that we avoid pathology. And so there are any mechanism that actually inhibits an immune response outside the central lymphoid organs is a peripheral tolerance response. And there are a couple. So one of them is the difference between clonal anergy or exhaustion. Go through this, really understand the difference between CTLA4 and PD-1 and how they work. I made this table like a year ago. I really like this table. I feel like it's a good table. Anyway, all right, Tregs. Tregs are my most favorite cell in the body, maybe second to CD8s. It's a toss-up. It's a hard decision for me. But anyway, they're pretty awesome. They are like the master regulators of the immune response. They tell everybody what to do and when. If they want the immune system to stop responding, it's going to stop responding, regardless of if the virus is still there. And that's part of how we have chronic viral infections like EBV, CMV, HIV. It's because these Tregs have decided, you know what, it is better to shut down this inflammation before we do some real damage. If the immune response has ended, they're going to stop. They're going to stop the immune response so that you can begin healing, okay? So they have a variety of ways of doing that. First off, they can secrete cytokines, namely IL-10 and TGF-beta. Just like the cytokines that induce Th1 T cells, like IL-12 and interferon gamma, IL-10 and TGF-beta will induce more T regulatory cells. So it's a feedback loop that promotes the T regulatory response. The other thing they do is that they make antigen-presenting cells kind of bad at their job. They secrete something called IDO, indoleamine 2,3 deoxygenase, which basically makes it so that the antigen-presenting cells stop expressing co-stimulatory molecules or like B7-1, B7-2, that's the same thing as CD80, CD86, or start upregulating things like PD-L1 that basically will interact with the T cells and tell them to stop acting. They also starve out the competition. So T regulatory cells have high expression of the IL-2 receptor, and that actually allows them to eat up all the IL-2 before any of the effector cells can, which means the effector cells can't proliferate, so you're starving out other cells. Okay, another way we do it is not with T regulatory cells, but there's actually mechanisms for cells to commit suicide when the immune response has ended, or to kill other cells, and that's fast ligand, so make sure you go through that. All right, then B cells. So not all immune responses are T cells, even though I think they're cooler. B cells actually also need to be stopped because antibodies can be really devastating. So here are the mechanisms of B cell tolerance. They can become anergic, which is basically the equivalent of a zombie. They just won't react. It's like my kid watching Pirates on TV. He loves Peter Pan. And I could throw things at his head and he would not know what's going on. Not that I do that because, you know, try to be a good parent, but I could. Sequestration. Basically, once the B cell leaves the lymph node, it might have a hard time getting back into the lymph node if it wasn't properly activated and it doesn't have the right chemokine receptors. If it leaves the lymph node, it can't maybe find its antigen, it might not get the right survival stimuli, and then it'll kind of dying just all alone out of the lymph node. The other thing is called inhibition, and this is actually an important one that revolves around this molecule. Fc gamma receptor 2 on the B cell basically shuts down the B cell. Okay, then we finally talk about memory. I've mentioned a couple times before that you can kind of track isotypes to determine if somebody's seen an infection before, you know, IgM versus IgG, things like that. the primary response versus the secondary response should be faster, right? The secondary response should happen faster. So we have this table that kind of differentiates between the two here. And then how memory B cells develop, once again, it requires T cell help. So go through this and understand what the role that T cells play. And I think I have a self-study question on this written. And the fact that IgG really dominates during the secondary immune response, which should make sense based on how somatic hypermutation and induction of memory B cells works. Okay, then we go into memory T cells. There's actually a cytokine-mediated induction of memory T cells. So we've talked a lot about IL-2 being IL-2 food, and it's true, especially for effector T cells. But memory T cells actually eat something else. They eat IL-7, which isn't as fulfilling, but it will make you live longer. I kind of liken it to veganism. So I apologize for any vegans in the audience. My cousin is a vegan and she's a phenomenal cook, but doesn't mean I don't want a steak sometimes. So I might not live as long, but I like steak. What can I say? All right, so off of that topic, but you've got different forms of food. So IL-7 versus IL-2. All right, and then the markers, how we can differentiate them. You see I lay out some mnemonics here, right? So CD45RA is for naive T cells, CD45RO for memory T cells. And I think that's pretty much it from an immunology standpoint. Okay, microbiology. We go into influenza kind of in detail. Like I mentioned, this is a major human pathogen. Give you a little bit more about structure. Some of it you've heard of before, like hemagglutinin and neuraminidase, but other ones you haven't, like the nucleoprotein and the transcriptase, which is really just these components, PB1, PB2, and PA. Know your functions of hemagglutinin. Know your functions of neuraminidase. You have to know the influenza replication cycle in detail. Kind of the detail I expected out of you for Walter Peters, okay? So hemagglutinin goes through it. I'm going to make a video about this in a second that takes you through all of these steps. Make sure you know it. Make sure you understand it. Here's a little bit about how it causes disease and how we defend ourselves from it. Don't underestimate the importance of antibodies just because we're looking at an intracellular pathogen. The flu vaccine that you get every year induces an antibody response that's really key, and that antibody response actually neutralizes the virus from being able to bind to our cells and infect them. Okay, know the difference between antigenic shift and antigenic drift. That's super high yield, super important, okay? All right, clinical syndromes, you guys can go through this. All of this pretty much is, you've seen some of it before, just go through it and understand it. Paramyxoviruses. This is a family of viruses that actually encompasses most of the rest of the viruses we're going to talk about in this self-study. So you've got RSV, parainfluenza, and mumps virus in here. So I go through the structure and I mentioned the replication. The main thing that you have to know about the replication for the paramyxoviruses are the two differences it has from the orthomyxovirus of influenza. So first off, influenza requires binding obviously to the sialic acid on the cell surface, and then it comes in and it's inside a vesicle, and then it needs an acidic environment to uncoat and reveal its genome. And for flu as well, it goes in and out of the nucleus replicating. Paramyxoviruses, on the other hand, they absorb by fusion and just release their genome into the cytoplasm, and the entirety of the replication cycle takes place in the cytoplasm. So those are kind of the main differences. If you know that, you're good. With RSV, understand that this is a really important pathogen for young children. We see a huge amount of hospital stays per year based on RSV. And causes bronchiolitis as well as other kind of severe effects in infants, and it can be pretty difficult. So understand how that works. Parainfluenza virus, this is like the flu, except it's like flu light. There are some that are pretty severe for children, but otherwise it pretty much just causes like a mild bronchitis, wheezing, croup. If you've ever heard that seal bark cough, my son actually had this last week, and the cough is so distinct that you hear it and you're like, ugh, croup, okay. And it's just a viral infection. It can be diagnosed, but it's not something that, unless the patient has some sort of extra difficulty, they're going to get over it pretty quickly. 2-day turnaround, not so bad. Measles. We don't see a lot of measles anymore, thankfully, but unfortunately it has been on the rise. In recent years, we're actually seeing more of it. And again, this is another one of those vaccine-eligible diseases that we're starting to see more of. It is classically known as one of the 5 childhood exanthems, which basically refers to the 5 childhood rashes. So these are viruses that cause rashes, and typically we saw them in children. So rubella, German measles, we haven't talked about that one yet, but it's caused by rubevirus. Roseola, we talked about a little bit. We'll talk about it more. It's a herpes virus. 5th disease was literally named this because it's the 5th exanthem of childhood. Basically, it makes like a hand-slapped appearance on the cheeks. Chickenpox, many of you are probably familiar with, and then measles. Just go through this, knowing how it gets in and out of the cells, how we get it, and then the clinical syndromes. The clinical syndromes actually follow a very specific pattern. So you start with cough, coryza, conjunctivitis, and photophobia, and then within a couple of days, you'll develop these Koplik spots that almost look like salt granules on the buccal mucosa. And then the lesions last not very long, 24 hours, 48 hours, something like that. And about 12 to 24 hours after the appearance of the Koplik spots, you're going to get this rash, this maculopapular rash all over the body, whole body. There are some severe complications sometimes associated with measles, specifically pneumonia, encephalitis, and there's some post-infectious encephalitis as well as some panencephalitic reactions that can occur with measles as well. We'll talk about these in your neuro block, okay? All right, and then you're going to diagnose this by PCR. All right, mumps, another one that we never used to see that now we do. You'll note that I'm using osmosis videos here in some places. The osmosis videos are actually really good for these two. So I've pulled them out where I think that they actually have already done a great job, so I don't need to re-record. This is another one that we're seeing coming back. Actually, in 2014, there was an outbreak of mumps in the NHL, as is shown by this poor Penguins hockey player here. And it turned out that, you know, some patients hadn't been vaccinated, or even ones that had, their immunity had waned, and it had been a long time since they had their boosters. So make sure you just go through the clinical syndrome and the diagnosis. And then adenovirus. Adenoviruses are a really massive group of family of viruses, a whole bunch of different varieties. The first 7 are kind of the most important. These are all the diseases it can cause, but really the first what is it, like 5 or 6 from undifferentiated URI to pneumonia are the most common, and you can see that children are the main population for these. Goes into the structure a little bit. You can see it has these fibrils on the corners. These are actually pretty toxic. You can see that they're on an electron micrograph. Here's the pathogenesis and how we get it, and then the clinical syndrome. So you're going to see an acute febrile pharyngitis, which kind of is exactly what it sounds like. You can get a respiratory disease. This one actually occurs, it appears to occur in military recruits. It's where they see a lot of it. And then conjunctivitis, basically pink eye, is associated with adenovirus. And then lastly, the common cold, rhinovirus. Just go through it. The important thing with it is really just that even though you're getting a great immune response, you're going to get the common cold over and over and over again because we don't really make a good memory response to it. Immunity wanes within a year, so next year you are still eligible for the same cold you had the year before. It's a bummer, but thankfully there's good over-the-counter medication. And that is the extent of the video. Here are your study questions, and as always, let me know if there's anything I can do.